Yeah, so women's health split into two parts. Right now, we're gonna go over non-malignant disorder, non-malignant breast disorders, breast cancer, reproductive problems, and infections. And then on Sunday, I'll go over STDs, reproductive disorders, and the hysterectomy. And I'll give you guys, I think you guys had to do this for homework anyways, but you guys had to do like an STD chart or something like that. Or maybe not homework, but it was like something they told you to do. It was like STD chart. So we'll go through that. I'll give you what I have on that, and we'll just talk it out. Split into two parts, so it should be a little bit more relaxed, hopefully. And maybe we'll finish a little bit early just because it's split into two. Okie dokie. You guys had this on Monday, right? The Mondays was a Monday lecture after midterm.
Yeah.
Yeah, I'm sure that sucked, but make sure my chat is okay. Okie dokie. So, with the non-malignant breast disorders, I think just kind of understanding a basic amount of them is good enough. I think I think women's health is I think the focus is actually a lot on the interventions and some things you have to know about. And I also have like a little chart I can give you guys after, but we'll talk about this first. So, with the fibroadenoma, can someone just like define what it is? Whoop. Maybe some signs, how it's described, stuff. Solid benign mass. Okay, that's good. Okay. What else can you use to define it? Yeah, it's gonna be easily movable, so that's like a really big thing about it. So easily movable, so you're able to when you're doing like your chest breast exam, you're able to move it around as opposed to like a breast cancer where it's firm, hard, and doesn't move around. So this one's does it hurt? Yeah, so this is non-tender as well. So that's pretty good. Um, Anything else you guys think about when you think of fibroadenoma? Just want to see what else you guys got in your brains. I think this is usually going to be good enough. The upper quadrant, I think that's typically true. Yeah, so it's typically found in the upper quadrant, so that's cool. So questions I can imagine coming up is just kind of maybe like a question where it's like the patient is goes to the is like going into the hospital, goes to the ER, whatever, because they feel a lump in their breast or something. And the question's there to see if you can differentiate the fibroadenoma between and the like breast cancer or something else that's going on. That's pretty much it for that. I'll throw in some pictures because I like it says needle aspiration. Yeah, so that's a thing you can do. So you can do a needle ultrasound or needle aspiration to determine if the mass is solid or if it's cystic, meaning it's got fluid. Um, so I'll write that down as well. So US ultrasound, I'll just write it out, ultrasound or needle aspiration. So if it is solid, how would you remove it? would you go about to try to remove it if it is a solid mass? I guess not you, but you wouldn't be doing this, but the doctor would. But if you got a solid mass, yeah, you want to get rid of excision. So excision, if solid, what about if it's fluid, if it's a cystic? So if there's fluid, how would you get rid of the fluid? You're already doing a needle aspiration. So yeah, you're already doing the needle aspiration to test it. You might as well just keep aspirating it. Yeah. Okay, so I like to think of fibroadenoma. I say F because fibroadenoma, F for freely movable, and for F for fake cancer. That's how I like to think about it. So this is one that gets mistaken for breast cancer. The main thing that really differentiates it apart is that it's easily movable. Okay. And I'll include some pictures because pictures are fun. So this is like osmosis. Some contains some extra information, but I like the pictures because it helps me connect it. For me, having pictures can actually just help me remember things, even if I don't use the information in the picture. In my brain, I just kind of like remember the picture and like the text next to it, if that makes sense. Just gives me something to like cling on to. Okay. So now there's the fibrocystic breast disease. So how would you describe this one? And how do we see that the word fibro is part of both? So what makes them similar? What makes them different? Some signs and symptoms or manifestations. That's true. So it is thought to be caused by an imbalance in estrogen and progesterone ratios. So um, when do you think it happens most often then? When in a woman's existence do you have a lot of hormonal imbalance? Yeah, so Kayla, yeah, so a lot of it's very common with menstrual cycles. So depending there's stages to it as well. And it can resolve after menstruation. Menstruation during that time we have the changes in hormones. So because you see here that it's caused by that imbalance, it's a way to really remember that it can be affected by and worsened by um, the hormonal cycles. So like imbalance in estrogen, progesterone. So let me see what else we have written here. There are a few stages, yeah. Okay, it's all true. Fullness, soreness, yeah. Associated with pain, tenderness, and burning. Cysts are smooth and mobile, may recede after menses, but do not disappear completely, may resolve after menopause, which makes sense. Menopause is also a big hormonal shift, but once that's happening, the the amount of hormones being put out is a little bit different. Um, so does this increase the risk of cancer, of breast cancer? Does anyone know?
Hey girl.
Oh, was that Kaylin? And they gave you co-host? Damn. Okay.
Oh, it was the dude at the front.
Oh, nice. Oh, it is the dude at the front. So what I asked them just now is, does fibrocystic breast disease increase the risk of breast cancer? Is that a potential risk factor for breast cancer? So on this one, it's actually not a risk factor, or it does not, at least it does not increase the risk of breast cancer on this one. This is kind of just caused by a hormonal change. Um, Kayla mentioned a lot of the symptoms and their stages to it. Here, I was just actually going to show you guys a picture because it helps me remember it. So this picture here kind of gives you some of the symptoms with fibrocystic breast. So similar to the fibroadenoma, you have lumpy texture. So you have like those bumps and stuff, swelling that goes along with it. So unlike the um, fibroadenoma, this can have some pain, as we see. Depends on your stage, but it can have some pain and tenderness. And it actually can come with a little bit of discharge, although it won't be bloody discharge, which is important to differentiate because we do have that going on with some of the other ones. And we do have the stages as well. Kayla already mentioned it, so I'll kind of just copy paste it here. So stage one, usually this can be associated with age. Kind of goes with, again, as we get older. Well, not me, I guess, because I'm not a woman, but uh, as women get older, the changes in the hormones and all of that stuff keeps happening. So, but someone with fibrocystic breast disease, it's gonna then present itself with some of these symptoms. So, someone in the early 20s with it can have stage one, premenstrual breast tenderness, fullness, but it gets better after menstruation. Maybe as they progress, as they get older, they might go into stage two and they start having more fullness, more soreness in multiple areas. And then as they get even older, stage three, you might start having a lot of pain, tenderness, and burning. But it's also something to keep in mind is that they are movable and smooth. And they might recede after the menses, but they don't disappear completely. And they may resolve after menopause, just like Kayla mentioned. Okay. So because there is so much info, I think the pictures help a lot. And hopefully you guys find it helpful too with to have the pictures. Okay. Yeah, so they're gonna be mobile. So I kind of highlighted this or bolded it. So they're gonna be movable, similar to the fibrous adenoma, which is makes some sense. They have similar sounding names, so that's something that you can kind of correlate with each other. Okay. The ductal ectasia. So how do we define this one? So from the name, we know it's something revolving, some sort of duct. Yeah. What duct is it? So what duct do women have in their breasts?
Is it the milk duct?
Yeah, so it's going to be that milk duct. So here we have some people answering dilation thickening of the duct, dilation thickening of the collecting ducts in the subareolar area. So this is your milk duct. And essentially what happens is they become clogged up with cell debris. And a lot of time that can be kind of like the fluid that would, I guess, become milk at some point kind of gets clogged up. It kind of gunks up. So you might also come with some nipple discharge, like greenish, brownish nipple discharge. You might have some pain and redness because think about like your like a duct in your is getting clogged up, so that can be painful. And you can have some like maybe like edema over the mass and stuff like that. And so Jennifer says it's like a firm mass as well. And I'm trying to remember if this one, I think this one is a firm mass, but it is not particularly palpable because it is deep within the breast. It's a duct inside of the breast. It's more deep within because it's a clogging of the duct rather than than like the fibrocystic like the benign growths that would be on the other two conditions. This one's just a clogging of the mammary duct. So it's not really going to be palpable, but if you were to be able to palpate it, it would be a firm mass. So it's like a firm mass, but you can't actually feel um, the cloggingness, I guess. You can't actually feel that little bump as much as some of the other ones. So good. And then just self-specified that it is the greenish brownish discharge. Yeah, little gunky. So I'll give you guys a little picture here just to help you remember. There's so many conditions all involving the breast, so having the pictures from me helps. So ductal ectasia. Here's a little picture. And we talked about, so most masses are not palpable, but it manifests as um, a firm mass. So you can't actually palpate the mass itself. Um, it comes with greenish brownish nipple discharge. You can have some enlarged axillary nodes, some pain, redness, edema. So, and this is, I think, more common with more older women. So as you're approaching menopause, it's more likely to happen, such as it actually says here in the picture. So kind of think of it like um, as we get like kind of like people like a risk factor for like atherosclerosis is can be like over time as we age, things get a little bit more um, more can things can thicken up or harden up. So as we get older, this kind of does the same thing. So it's more likely to clog. This is kind of like atherosclerosis for boobs and or milk ducts rather. It's like a way to think about it. Trying to make this. Okay. So greenish, brownish nipple discharge and large axillary nodes, pain, redness, edema over the mass. And get this one in there. So a benign breast tissue common in those approaching menopause, caused by the dilation, thickening of the collecting ducts, and they become distended and filled with cell debris. Okay. Any questions on anything so far? And then if you do have questions, refer them to Kaylin, the resident female tutor, because I'm not a woman. You hear Kaylin? Did you hear my joke? I think she's not. I think she's like in her car or something.
No, I heard you, but I'm trying to get ice cream,
Oh, fair.
so I don't have too many hands.
Okay. So now we're gonna go over intraductal papilloma. So intraductal, it means inside the duct. Oma means a growth, and papil, I actually don't know what the papillo means, but I think that means um but oma means it's like a growth. So it's like a benign tumor. So what can you guys tell me about intraductal papilloma? So we have ductal ectasia and we have intraductal papilloma. Yes. So this one here is just clogging of the milk duct, while this one here is a growth. It's a tumor a benign tumor in the milk duct. So abnormal but benign growth in the milk duct. Perfect. Mammary duct. So what is like a defining characteristic of your intraductal papilloma? So here we had some green brownish discharge. What kind of discharge? You can imagine this will have some sort of discharge. What kind of discharge would it be? That can be one, yeah. Like I think a discharge in one nipple is a yeah. So that's the big one here is that it's bloody serous discharge. So that was a key differentiation between this intraductal papilloma and the ductal ectasia is that this is a green brownish discharge. It's really just the clogging and gunking of dried up milk duct, while this is a bloody serous discharge you can caused by a benign tumor. And I think the other ones here, like this one also here, when we talked about fibrocystic breast, the little picture here mentioned specifically that's free of blood. So that's kind of your big tell for the intraductal papilloma. Um, it's that bloody serous discharge is going to be your focus. Okay, and just in case it becomes relevant, I'll put that occurs most often in women about 40 to 55 years old. And then how would you get rid of a growth? Similar, think about the way we talked about the fibroadenoma. So yeah, it can be excised. And we'll get rid of the duct too. Okay, and then I have a picture for you as well. Let us put this picture here. Boom. Maybe that's a little too big. Okay. So here, benign tumor, intraductal papilloma. Here's kind of like a picture showing you what it would look like if you were to look inside. It here reminds you of another key trait is that it has discharge from only one nipple. And yeah, just remember the bloody serous discharge is really what's going to define it. And now we can talk about gynecomastia. So um this one's more going to happen for men actually. So what do you guys think about gynecomastia? Pretty much it's going to be breast enlargement, so like non-inflammatory breast enlargement. Yeah. So what do you guys know about the cause? Someone already said due to estrogen excess. Great. And how do a lot of people end up having estrogen excess? There's there's like like bodybuilders. How do they end up getting estrogen excess?
From the steroids?
Yeah, so they're taking anabolic steroids. So when the body has an excess of testosterone, the body actually converts it into estrogen. The people that take anabolic steroids, they're also kind of having that overflow of estrogen, so it can lead to gynecomastia, as well as a few other things. So some of the stereotypes you hear with like steroids, it's gonna make your jewels shrink. That's a possibility because you're basically getting a lot of estrogen. You get breast and other stuff like that. There's also a few other ones that they mention here, but a lot of it is just caused by um, the estrogen excess. And then I have a picture of The Rock with some breast there. wanna mostly on this right side, on his right side here. This one seems like it's okay. This one you can kind of tell. It's got that like that pointy. I think that's kind of like a trait of the gynecomastia in men is that they have kind of like pointy nipples. So some of the causes can be anabolic steroid overuse. It can come from spironolactone because it blocks androgen production. Okay, and it can also happen in puberty because you have a big change in hormones. Mm, cool. Anything else you guys know about gynecomastia? Or are you guys cool with that? A lot of the time, it's pretty benign. It is just kind of like an appearance thing. It's definitely something that can psychologically affect the person. So it'd be a lot of maybe like although you can't take medication for it. So I think the med used can be tamoxifen, I think is the one they specify. But I don't think it's a huge focus. Just kind of knowing what it is probably good enough. But it's a lot of psych would be like reassuring the patient because body image can be something that affects them, especially if they're teenagers where they're probably being made fun of and stuff like that. Yeah, it doesn't really require treatment, especially when they're in puberty, because they'll just go away once their hormones kind of fix themselves. Yeah. All right. Any questions so far? We went through pretty much all of the non-malignant breast disorders, and then we can move on to breast cancer. Do you need to know the meds? So I think I can't definitively say just because I think they're probably, I'm sure it seems like they changed your guys' tests and stuff, so I can't really definitively say. But for us, it wasn't really that big of a focus on this. For us, it was kind of just knowing the conditions, being able to tell apart fibroadenoma from like a breast cancer, maybe some of the key factors that makes the mammary duct ectasia different from the intraductal papilloma, so the discharge and stuff like that. Gynecomastia is kind of like an oversight. I don't think it was particularly um, emphasized. I just really like this picture of the rock, so I need to teach about it. Kidoki. Still got, yeah, we still got some time here. Okay, so I think again, we talked about risk factors with your atherosclerosis and hypertension. So I think it seemed like that session went pretty well. So we'll focus again on some risk factors for breast cancer. Oh, and before I forget, actually, I'm going to give you guys this, and hopefully this helps as well. Just kind of having it all together in a chart. Look at that. So hopefully this is helpful as well. I feel hopefully the ones we did with Crohn's and ulcerative colitis, we had like a similar kind of table. Hopefully that helped for the midterm. So hopefully this helps you guys as well for I guess it would be your final at that point. Okay. So, let's think up of some breast cancer risk factors. What do you guys got for me? Yeah, so more likely and more common in female. So being female, age, so age 65 plus. Smoking, I believe. Let's see. I think it might depend on the type, but it's generally, yeah, history of previous breast cancer, breast or ovarian cancer. I'm sure smoking is one, but it might depend. I think I think there's some where it's like more common than others. Um, Family history for sure. What else can you guys think about? Yeah, so there's some genetic factors, and it goes with the family history, like the BRCA1 or even the BRCA2. What else? So does having children or not having children affect anything? Yeah, so your breast density. So bigger breast, more space to, or more chance of having that abnormal growth. Yeah, so let's see. Jennifer not having children. Yeah, so never, this is called nulli gravida, which is never been pregnant, especially if over 30 years old. So never being pregnant, never haven't been pregnant increases your risk of breast cancer, especially if over 30 years old. Nulliparity is not exactly the same. Nulliparity is never actually given birth. So you might have been pregnant, but you got like an abortion or miscarriage. Kidoki. And then yes, so Giselle mentioned an Ellie menarche, menarche being the first occurrence of menstruation. So early starters increases your risk of breast cancer. Probably has something to do with your hormones, if I had to guess. I think a lot of breast cancer medications are hormonal, estrogen um, related. And then there's one more kind of has to kind of like the opposite of early menarche even. So if early start is one, what's the opposite of an early start? Yeah, a late menopause can also be one. Again, also probably related to some hormones and stuff. And of course, just because the higher risk is on female doesn't mean that men can't get breast cancer because they can. Okie dokie. So there are definitely some different types of breast cancer. There's the infiltrating ductal carcinoma. It's the most common one. But for now, we're just gonna try our best to just kind of cluster them into just thinking about breast cancer. So what do you guys think about as some manifestations of breast cancer? And try to think about things that differentiate them from the fibroadenoma, which we talked about is freely movable, F for freely movable, and for fake cancer. So this is something that people can confuse for breast cancer. So think about some things that differentiate it from that one. The breast dimpling. Yeah, the skin. What's that called? Do you know the name of the technical name for it? It's like a French name. I'll give you a hint. It has the word orange in it. Yeah, I don't know how to pronounce that. Peau d'orange? I don't know. So it kind of looks, if you've seen it, it actually kind of does look like, they call it the orange peel appearance. And it actually genuinely does look like an orange peel. I'll give you guys a picture of it so you guys can actually picture it instead of just kind of hearing it. I'll just put this here. Like that. You guys see how it actually kind of does look like like an orange. What else can you guys think about? So if we had movable masses with the fibroadenoma, what do you think happens with breast cancer?
Non-movable,
Yes,
non-movable.
exactly. So it'd be a fixed, immovable, um, I would say it's like a poorly defined mass. That is the main thing that really separates it, is that fixed, immovable. It's not really uniform. It's just however it grows. So poorly defined, like irregular, regularly shaped. It's hard, firm. Does it hurt? Is it a painful thing? No, yeah. So think about why they make, or they don't make you, but why they recommend that women do the breast cancer check. They do the check is because you don't feel it. So you actually have to, you don't feel it as in like you don't feel pain. So you actually have to feel around for lumps. Yeah, it doesn't really have symptoms, so it goes undiagnosed. So they want people to feel around, try to see if they find lumps, and then you want to see if it's a movable or immovable lump. So it's non-tender. So that's like a big thing with that. So along kind of with the orange peel appearance, it also kind of has like a little bit of edema. So it kind of swells up, has that dimpling. Um, what are some other things that you can think about for this? Maybe let's think about now like some labs. Yeah, so typically the Pute Orange and all this happening, this is like advanced stage. But something that makes it unique. While early on, it'll probably just be more of this right here. I think if you want to be specifically, it's in the tail of Spence, which is a specific part, yeah, of a specific area. I spelled tail wrong somehow. Okay. So this upper part here, you see how the breast is right here, like that yellow stuff? It's this upper little piece right here. This is actually a better one. The tail of Spence. Yeah, it literally does look like a tail. That's where it's most common. Okay. So yeah, what are some labs that you might see? And things to keep in mind are how breast cancer, it can metastasize. So think about where it metastasizes and what labs might be affected with your metastasis. All right, let's see what you guys put down. So Giselle mentioned the liver. So yeah, for sure. Say it with confidence. Do you know or do you think it? Say it with confidence. Yeah. So your liver, so your metastasis, liver, all caps, period. So your metastasis with breast cancer is most common in bones lungs, brain, liver. So with labs that kind of go along with that are going to be your LFTs, as you guys can imagine, your bones. So we can think about your calcium. So this is your AST, ALP, alk phosphate, and maybe some bilirubin and all this other stuff. Your calcium levels can suggest metastasis to the bone if we have Um, I, bel I believe it's like increased blood calcium because then you have your bone breakdown. So that's where you get some of that bone pain. So maybe your calcium levels are messed up. Someone mentioned pulmonary. So yeah, something to assess would be your pulmonary. So someone mentioned actually ABGs, and mentioned ABGs. I can definitely see that being one. I think it wasn't specified like for that, but that makes perfect sense to me that it might start to affect some. Yeah, but it'd probably be like a super late sign. But it's yeah,
Also depends what part of the body metastasizes to.
yeah. Can you guys hear Kaylin? She's talking right now.
Hi. What?
I think we can't hear you
Oh,
Uh,
a bit.
a
Okay,
bit.
here. Give me that. Thank you. Hi. Hello, everyone. What was I saying? Oh, the lungs. Right. So it's basically wherever it metastasizes to in the lung. If it's lower, it might not cause anything. You guys will learn this in 232 as well with lung cancer. You guys go over there. But if it metastasizes to different parts of the lungs, it causes different issues. That's why ABGs could be affected if it's in a part of the lungs and it affects oxygenation. But that's just depending on the size of it and where it's located. Thank you.
Thank you for coming to my TED Talk. Yeah, so yeah, awesome stuff on that. Awesome possum, she says. So maybe some of the BC markers. So we said it's got some like BC markers. Whatever that means, honestly, but BC markers. Oh, so true. Yeah. So what are your breast cancer markers? I don't know, but they're there. Actually, I genuinely don't know what the breast cancer markers are. Let me see.
It's CEA 15-3,
Oh, damn.
CEA, and CEA 27
Damn.
I was like, for some reason,
Was that from lecture or from work? Work, right?
from both.
that's from
Oh, both. Oh, damn. Yeah. Nice, nice, nice.
I just heard someone talking. I'm like, I bet that's Rosemary.
Yeah.
'Cause she's
Awesome.
like, this is
I think all they did in class was be like, yeah, breast cancer markers. I'm like,
yes.
awesome. Tumor markers, yeah, that can definitely be one. You're maybe like a CRP,
Elevated
inflammatory markers. You could have like stuff like that happening. But I think your main thing is just kind of think about your metastasis. Where can it go? How if it starts to affect these organs, then we know that there's something going on. Although again, metastasis is a little bit more of a later thing. So another thing I guess nobody really said is ulceration. So you can have ulcers, nipple retraction. So like it will quite literally, your nipple will hide. It will be like, I'm out of here. I'm like, I don't want to see this. So maybe we can see some of that. Any labs for the brain? I think when it starts, you probably first thing you'll probably end up seeing would probably be altered level of consciousness, maybe like really bad neurological deficit. Anything else that you might see for like a brain metastasis?
If it's across the brain, it can compress and cause like what
For brain, they get a lot of headaches,
Hmm.
confusion, forgetfulness.
Yeah, that makes sense. Yeah, so that yeah, pretty much yeah, the altered level of consciousness, specifically some headaches. ICP probably like increased ICP, I imagine. What was I gonna look up, fellas? Fellas? Oh, the ulceration. Breast cancer ulcerations. And you guys can enjoy all these delicious pictures. Yep. So that's What can happen? Wow.
Wow is an understatement.
So let's see what we can get here. So you can see, I guess it's not the best picture here. But there you go. So that's your nipple retraction. It kind of does look like it's smiling. Yeah. So you might get some nipple discharge too. Awesome. So I think we actually talked about, we didn't really, well, someone mentioned a little bit of the screening, but what's your definitive screening thing? Like, yeah, how do you definitively diagnose breast cancer? Breast cancer?
Mammogram's a good screening.
Yeah, mammogram's screening. It's definitely a good screening, but it's not your definitive one. This is something that alerts the doctor to
Needle
be like,
biopsy.
yeah, you need to do that biopsy. This is your definitive diagnostic to diagnose breast cancer. And your mammogram is good for early detection.
Be like it could be one of the earlier things that they see that was talked about, the non-cancerous breast disorders. Is there a specific discharge color? Ooh, that's something.
Let's do something. Let's do this and find out. Good luck, everybody. All right, let's see. So it looks like red, pink, or bloody, which actually makes a lot of sense. Remember, the papilloma was a bloody one, so it makes sense that with breast cancer you'll also potentially have a red discharge. I'll give you guys this one. It's a pretty good picture. What else? What's something that you can do right now? As an early detection tool.
Self-breast exams.
Oh yeah. Self-exams. Awesome. So that's something you guys can do. Here's a um, here's a picture for the boys. Because we don't do this. So we should still do it, but like we don't. But we do. We should. So yeah, it's a monthly. Yeah. So what else can you tell me about mammogram? So it's good for early detection, but what else? Um, what else about it? Yeah.
They can
Who's it?
do a diagnostic.
Hmm?
They can do a diagnostic. Once they find it, they'll do a diagnostic where they can just focus on that area only.
Mm-hmm. Good. What else? Who's it for? Like
What age?
what age group?
Sorry, annually.
Oh, 40 and above. But they doing it younger now.
Yeah, they're doing it younger now. It seems that it's breast cancer is becoming a bit more common with younger people, so they're starting it. The reason that they were starting it so late was because they were saying it's a little bit less accurate um, based on, I believe, the density of the breast. So they were like, it's not reliable enough, so they weren't doing it until 40 up. But now that it's happening more often with the younger people, they're starting to do it a bit more early. But for class, we were taught 40 plus, so that's how they'll test us. So that's just what we got to keep in mind. And then before the test, what are some things to do or not to do rather? So education before, what are things that you don't want to do?
You saying for the mammogram?
Yeah, for the mammogram.
They don't want you to put any deodorant, lotion, things like
Yep.
that.
Exactly. So no deodorant, spell deodorant wrong. No creams, lotions, powders to the breasts or underarms because it can mess with results. Yeah, and this is good for early detection. So if they detect something, can then as like Rosemary mentioned, and then follow up. Awesome. hmm Okay. So self-exam. So here, based on the picture as well, just know that there's a specific way to do it. So usually they say to kind of do it in circles. So just kind of follow the picture, I guess. Yeah, don't lift. Yeah, that's another good one. So don't lift fingers off the skin. Do it in circles. Blah blah blah. Basically just the way to actually do it. So I could see a question being like, okay, you guys know how to do breast exams, but then they ask you specifically, like the patient's like asking you to teach them, so you can get got from something dumb like that. So just make sure that you kind of um understand that. One of the clinical exams. Okay, yeah. Okay, I guess I'll put it right here. There's the clinical exam. So essentially, yeah. So I don't think they can hear Caitlin, but she said, "Why is that?" So to do it 1 week after menstrual period. What did we talk about that seems to go on during the menstrual period? Menstrual period, menstrual cycle.
The hormonal changes.
Yeah. So what's a specific condition that we talked about?
The fibrocystic breast.
Exactly. So that can remember that the fibrocystic breast and the fibroadenoma kind of have a lot of similarities. So this stuff can be confused for breast cancer. So it's not going to be as useful for your self-exam if you're doing it around the time that this is going on. Cool. And then there's the clinical exam, which I think I'll just give it to you guys. Just essentially it's kind of like it's somewhat like it's basically you're going in and they're doing the breast exam for you. Yeah. And yeah, so can I mention they're also doing they're palpating the talus bends, assessing for enlarged lymph nodes, and stuff like that. So yeah. And yeah, the sentinel node, so I'll just give it to you guys here. So clinical exams should be done every 3 years for those over 20 and annually of over 40. It's pretty much the same steps as the self-exam, except they start palpating the talus bends, above and below the clavicle, and they really want to check for enlarged lymph nodes. So probably the key thing to keep in mind here is that the sentinel nodes are assessed most for lumps. So the sentinel nodes meaning the nodes that are closest to where like an actual like mass would be. Yeah. So here's one right here. They already give you well, I guess you guys got to see the tail spence. We'll do this here. So sentinel lymph nodes are lymph nodes closest to the tumor. So if we're saying that can happen a lot in the talus spence, that's where we're really going to be also focusing in on. And the sentinel lymph nodes would be lymph nodes around that area where an actual potential tumor would be. Okay. What else do we got? We got management. And I think this is like a key thing to focus on for breast cancer. So how do we manage breast cancer?
Early detection.
That's fantastic. So yeah, early detection is key. So this is again your preventative stuff. So what kind of prevention would that be? Is that primary, secondary, tertiary? You guys remember that from like 210? Yeah, it's your primary detection. That's your primary detection. Is your breast self-exam a primary, a secondary, or a tertiary? So remember that your primary, oh yeah, sorry, my bad. I kind of messed that up. I guess it's like primary and secondary. Yeah, so remember that your screening is secondary prevention. Primary is kind of things you do to avoid it. Secondary is things you use to test it. So remember that self-exam is a secondary prevention. Because you're essentially doing a quote unquote screening on yourself. What else can we do? So direct management now. Chemo and radiation. Chemo and radiation would be like actual treatment. So prevention. So chemo and radiation is not done, is not really, I don't think it's really done prophylactically. It's just gonna be, it's when there's an actual problem. So that would be at that point. Um, that wouldn't be considered a prevention. Self-exam again, it's because we're seeing if we have something, so that's screening. Your primary is teaching, um, that helps you prevent it from even happening altogether. Your secondary is screening to see if you do have something now. And then tertiary prevention is essentially your management. So I would say, if anything, chemo and radiation would be like tertiary, but yeah, so people are talking about chemotherapy, radiation, and then the one that I think the biggest focus in on is your mastectomy. So what do you guys got for me in terms of mastectomy? I think this is a humongous focus. And this is, I guess, yeah, I'll do mastectomy, lumpectomy. So surgical lumpectomy. Don't use the arm too much. Keep it. Actually, you want to be using your arm. You want to keep it elevated. That's good. So, yeah, but you do actually have specific exercises for um, the patient, the post mastectomy exercises and stuff. Yeah, hand squeezes was one of them. Cool, cool, cool. So there's the different types. So lumpectomy, quite literally, is you're taking out a little bit of a lump. Then there's a partial mastectomy, modified radical mastectomy. So the difference between them, I kind of just want to put the main differences here and then talk about mostly mastectomy. It seems to be the most common one that I see. Sure. Okay. What stages do they do lumpectomy? Yes. So Kaylin asks, why not a different stage, 3 or 4? So why is lumpectomy not done for stage 3 or 4? Yeah, at that point it's grown way past the point where we could do a lumpectomy. Yeah, Kaylin's directly calling you out, Jennifer. She says stop putting question marks if you know, and she says and then she says you know your stuff. So say it with confidence. Change. She's saying yeah.
Yeah,
Yeah,
confidence, Miss Girl.
yeah, period. So then for stages 1 and 2. So yeah, another thing is that the lymph nodes are not removed for a lumpectomy. And radiation follows. So again, here's another picture for this. Pictures are nice. So you can see they quite literally take a little lumpy out. Yeah, now you have a little crater. You can put milk in there. It's like a little cereal bowl. Uh, So I'll just kind of have these ones, the partial mastectomy. So this one, I spelled mastectomy wrong. Sorry guys. I'm gonna die now. Yeah, this one I'll just kind of go over because I really just want to focus on mastectomy. So cancer is removed along with some normal tissue and lymph nodes. So that's this one you will start doing your lymph nodes now. So this one includes lymph nodes. Your mastect, then there's still like a modified radical and there's a radical, but for this one we're just gonna focus on the modified radical mastectomy. Okay, so tell me about this one. All right, so let's see what you guys answered. So we talked about removal. So yeah, so with this one, it's a little bit more accurate to say that you're removing breast tissue, skin, axillary nodes, lymph nodes, but the muscle, some of the muscle and the nerves are left intact. So, like Fidel mentioned, it's the underlying muscle and nerves left intact. Giselle mentioned that you can have reconstruction after, and this can be done like right after the surgery, or it can be done months after if they decide that they want it after. And yeah, I mentioned the lymphedema. So we're gonna go in specifically over post-op because that's like a humongous, probably I think that's the most important part when it comes to the breast cancer is really understanding your post-op. And this is something that you can apply to clinical because you'll actually, I've had like a good amount of patients that had like history of mastectomy, and you have to keep that in mind because it affects how you do certain things, and we will talk about that in a little bit. Okay, so I'll write it down here. Awesome. What else did you guys mention again? Yeah, so that's true. Reconstruction, yeah, so reconstruction can be done immediately after or several months after. Okay, so now let's talk about post-op. This is your biggest thing, I think, to focus on for mastectomy, for sure. So what are some key things that we really need to do for post-op and even for someone after, like months, years after? So yeah, Giselle mentioned the lymphedema post-op. So you're gonna they can have that lymphedema, so you're gonna want to do a few things for it, such as yeah, so Jennifer mentioned that as well. So yeah, so no BP or blood draws, no BP, blood draws, or IVs on the affected side, and that's forever. Forever. So that's something to keep. So that's something that you keep in mind. If you have your patient with a history of mastectomy, is that you are not going to be doing the blood pressure on that side. So either you'll have to keep this in mind, or you might even see, at least at the hospital that I go for clinicals, you will see, um, you go walk into the room and there'll be a sign that will say no BP on left arm, no BP on right arm, whatever. So it's something to keep in mind. Um, and why do you think that is? Why do we not want to do that on the affected side? Ah, yeah, so in the meantime, pain, not inherently. That's
Because lymph nodes are removed.
yep.
Possibly, but not really much.
Yeah, so remember that their lymph nodes were removed. So at that point the blood pressure is going to, sorry, not the blood pressure cuff, putting all that pressure in the arm. We don't want them to, yeah, what does it do? So why do we not want this? So Rosemary mentioned that it's because of the lymph nodes. So what happens if you do, or like what happens? Yeah, not quite. So we mentioned that they can have lymphedema. Do you think they might be related, or do you think they're unrelated? Are they cousins? Are they first cousins, second cousins?
First cousins.
Yeah, so this is like directly related to each other. So the blood pressure, the blood draw, the IVs, all of this stuff can actually affect and can even cause the lymphedema to occur. So we don't wanna mess with that. So our biggest concern is the lymphedema. So we are gonna do this we're gonna not do these things to avoid that from happening. And then when they do have lymphedema, someone mentioned that they can do the lymphedema sleeve. And then they will also have some signs and symptoms of lymphedema. What do you guys think about on there? Or like how would you even define it? So this is like a
What
lifelong. Oh, sorry, go ahead. I couldn't hear you.
swelling and pain.
Oh yeah. So this is gonna be so for sure we're gonna have pain, swelling. Um, what else can you think about? Someone said redness. Not inherently, but somewhere along that track of perfusion and all that stuff going on. Yeah, so numbness and paresthesia. So it says all paresthesia, numbness. There can be some heaviness as well. So that lymph, uh, so the way it's defined, it's the the nodes cannot return the fluid through the central circulation, so you have an accumulation of fluids in the area where you are lacking the lymph nodes. So if we kind of put pressure or do any of these things, we can end up having that accumulation of fluids in the area. You can have that pain, swelling, numbness, tingling feeling, heaviness, all of that. And then interventions. Talked about the lymphedema sleeve. What else is really important that they go over when it comes to, yeah, elevate the arm is good. I should have written that for more. What else?
They want you to move the arm too. They don't want you to just keep it stiff.
Exactly. So that's the post mastectomy exercises. And I got a picture for you guys as well on that. Because like the pictures on this one. Ooh. It's too far over. Okay, so I gotta do this. Where? How do I get it on the other side? Guess we could do this. Oh, it still does it. That's funny. Okay, I can figure this out. I got this. Never mind, I don't got it. I don't know why it's doing that, but you guys got the idea. Maybe I can make it a little bit smaller. Yeah, there we go. So these are some examples: brushing the hair, kind of moving your arm like your yeah circular motion, doing things like you're reaching for the sky, like go up to a wall and like try to like climb it. Yeah, so all of these things for you to do. Some other things is just kind of education on a few things here. So, continued mammography and your monthly self-exams. Remember, one of your risk factors for cancer is um, previous cancer. So you got to keep up even after you already go through it because it can come back. It can happen again. So that is a big deal with that. And now, okay. So some other things to keep in mind is you're going to do your routine vital signs, which is obvious, PQRST, kind of everything that kind of goes with that post-op and stuff. This person's going to be on going to have a JP drain. So what are some things that you think about with the JP drain? You guys all know what that looks like? It looks like a little hand grenade. So what's an important thing with it? Yeah, negative pressure. So when you're emptying it, you're gonna unclip it, dump it into like a graduated cylinder to get the more accurate reading. Um, yeah, and then after it, you're gonna re-squeeze, keep it squeezed, and then you're gonna cap it off. Perfect. So you're gonna ensure that the JP drain is compressed to create the negative pressure. Yep, so you're gonna be assessing the color, amount, all of that good stuff. Yeah, I got to do that. Was it Tuesday? Mm, I don't think it was Tuesday, but I think it was like last Tuesday. So two Tuesdays ago, I got to do that. All right. So what are some things where you would be calling the doctor for? How much is too much? Yep, exactly. So more than 100 ml, like especially post-op day one, we're gonna call the MD. And then how much in a period of 24 hours do we think is little enough that we can think about stopping the JP drain or just not having it anymore? Close. It's like less than 30. Yeah. Good job, Jennifer. And she said, oh wait, she said, ugh, girl, you gotta put that period in there. So you had the right answer. There you go. Awesome. So yeah, there's a lot of stuff we just covered there. Any questions on breast cancer? So again, I think your priority is a lot. Show it normally. Yeah, cool. So I think your big priorities has to do with your mastectomy, your post-op for mastectomy, being able to understand your primary, secondary, early detection is key. Your self-exam is like a secondary prevention. Um, blah blah blah. It's monthly. You don't take your fingers off. Biopsy is always your definitive thing. And knowing that peau d'orange, however you pronounce that, peau d'orange is a late stage sign, and that it exists. It's a fixed and mobile as opposed to the fibrocystic or the fibroadenoma. Knowing some of your risk factors, I think, is any other examples of secondary prevention? Yeah, so your secondary prevention includes your mammogram. So any screening is secondary. Yeah, so that's a good one. Caitlin just said that it's um, secondary uh, S for screening. So mammogram, um, even your yeah your self exam, clinical exam. Um, yeah, the biopsy is also screening. All of those are screening, while primary prevention is, I guess detection. Ooh, I just spilled. Yeah, your primary is like things you do before you, like things you do to prevent it from even happening in the first place. Um, no, not really. Okay.
It's in your keyboard.
Hmm? No, not, it's actually very small spillage in here.
Okay, so wait. I don't trust you with liquids. You're gonna spill. Get you a sippy cup for your birthday.
I need a sippy cup? That's crazy. Okay. Yeah, let's see what things, yeah, for primary. Yeah, just like lifestyle. I mean, there are a lot of these are actually things you can't really change. Not most of these are not very modifiable. I think, yeah. Primary is a little bit hard for breast cancer because there's not much you can modify. I think obesity is actually a risk factor as well. So maybe that can be something.
Diet. I don't think there is for this type of cancer.
Yeah, Kaylin says she doesn't think there is for this type of cancer.
Where's my chime in? Where's my girl at?
Wait.
She's gonna be like, actually,
Mhm.
wait.
Yeah,
Wait,
but yeah, any other questions or comments? That's perfect. I'll give you guys something else too here. About this one. So here's another little table picture thing. Breast cancer, your types, some of your risk factors, all kind of in this one little area alongside. Yeah, I think we said alcohol. Maybe we did. Oh yeah, I guess. Oh yeah, I guess that's a primary one. So obesity and alcohol can be one. See, look at that. Learning stuff.
Already.
Yeah, so pretty much when in doubt, stop smoking or drinking alcohol. Yeah, manage weight. The usual. The usual. All right, so now we're on to reproductive problems. And this is a little bit of a shorter section. I think so we should be still good on time. So your premenstrual syndrome, your PMS, um, uh, what are some signs and symptoms of this? And maybe I can add here for you guys the definition. And you guys can just tell me the signs and symptoms. Irritability, yep. Cravings, headaches, for sure. What are some other things that you guys can think of?
Bloating.
Bloating, yeah, that's a big one. Bloating, so that kind of goes with the edema here. Insomnia, I'm sure that could for sure happen. Mood swings is one. Those are probably like the main things to really go over here. Yeah, I think migraines are one, I think. Yeah, headaches, migraines.
I like that she put the sad face with that. I
Yeah.
felt that.
I don't know if you guys
You
can.
don't understand, though.
I really don't.
I know you don't.
I don't know if you guys can hear Kaylin too well.
The girlies get it.
Oh, the girlies get it? Okay.
Yeah.
I mean, yeah, I guess so.
Don't understand.
I really don't. It sounds like it sucks though.
I love the fact you're mansplaining it, though.
Well, I can't help it. I'm supposed to do it.
No, but it's kind of.
It is funny though. Cramps and tender breath, Celeste said. Wait, why she?
Oh,
Oh,
she accidentally private messaged.
oh, that's funny.
Tender breast, yeah.
Yeah. Oh yeah, cramps for sure.
Oh, I try to be. Thank you. I'm gonna leave this profession and be a comedian. I could be like Nurse Sean.
You could be, yeah, or like the other guy, Steve. Steve.
Yeah.
Yeah.
Oh,
Or stuff.
yes. That'd be fun.
That'd be interesting. All right, so what about some management? This is a little bit interesting because it's very contradicting on some of these things, but there's some general teaching. So how do we decrease the irritability? Yeah, you guys aren't gonna like it, but you guys are gonna have to decrease the caffeine and salt. Ah. Kaylin's just like pops out this ghost energy drink. She's like, I'm drinking this right now. It's like, oh, 200 milligrams, 220 of caffeine. Oh, and it's gluten free. It's okay, guys. So, decrease caffeine. Irritability. Yeah, decrease salt because that can help with the decrease edema. Edema and bloating. Awesome, awesome. So there's like a controversial medication. It's like over the counter, Midol.
Nothing
Kaylin says this don't work for nothing
for me.
for
some
her.
people, it's like a miracle worker.
So this is Tylenol, and it's actually caffeine. So it's like,
caffeine, it's diuretic.
so it's very weird because it tell you to stop caffeine, but it's probably just like
I think the amount.
it's just the amount most likely.
Because it's a very small amount that's present in the Midol, if I remember.
Heating pads, yeah,
Yes.
that works great for her.
What?
What?
Somebody put the prayer sign. Ooh, raspberry tea leaf.
Actually, yeah, did they mention that?
They don't,
They
but-
don't, but yeah,
But
It-
the girlies get
the
it.
girlies get it. Yeah.
Yes. I'm gonna have to try.
What, the
don't-
raspberry tea leaf?
Yeah.
Okay. Awesome. So that's pretty much that. So your focus is just really treating the symptoms. Yeah. So another thing that works is exercise because it helps with mood. For me, that helps with anxiety and stuff as well.
I feel like it makes me less bloated.
Oh.
I don't know if there's a science to it, but I feel like.
Maybe you're sweating. I don't know.
Oh, that makes sense.
You're
Yeah.
technically releasing sodium when you're sweating. So
Sodium and water. Okay.
yeah, maybe that helps with your bloating too. I don't
Oh,
know.
maybe. Yeah.
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 All right. So dysmenorrhea, the definition of it. So we're almost done, guys. Very close. Are there any guys in this? Oh, there's Fidel, yeah. Fidel, Doneen, Khaled, Sebastian. All right, the boys are here. So what does this mean? Yeah, so Bria is like discharge of men. Men actually means like woman actually, or like basically just saying it's like a irregular the discharge irregular and relating to like women. So in this case, menopause. Yeah, well, menses. Yeah. So irregular menstrual discharge, or lack in this case, specifically, it's the painful menstrual discharge or flow.
This just means like non-function of sorts. So it's not functioning correct. So that's why it's not like amenorrhea.
Yeah, so this is due to a release of prostaglandins, and that's relevant because of your stuff.
The prostaglandins are the thing that makes you poop.
Prostaglandin. Prostaglandins is like a general inflammatory thing.
Yeah,
It does a lot of stuff actually.
it can make you have period poops,
Oh,
Yeah.
like cramping and spasms.
cramping, spasms, back spasms.
Yeah, so it's common. It says, according to my notes, it says it occurs in 50% of 50% of women report some degree of it.
Yep.
That
I'll tell them to remember prostaglandins because it's coming up in 222 as well. That was a thing.
Oh, okay. Yeah. Kaylin said to keep in mind the prostaglandins because it comes up a lot in 222 because then we start going into OB. So that's like a common thing just to keep in mind here. So what's some management that we can think about for this? Like three that I kind of probably the biggest ones. Kind of have to deal with that prostaglandin, a lot of it.
So if I have too many prostaglandins, if I have too many prostaglandins, what can I do for that? Ibuprofen, NSAIDs,
NSAIDs.
Profen.
NSAIDs. So those are prostaglandin inhibitors, or that's one of their functions is inhibiting prostaglandins, which we talked about being an inflammatory thing. And remember, NSAIDs are non-steroidal anti-inflammatory. So look at everything is coming up. Everything's coming up plankton. All right. Yeah, helps with pain and decreases uterine spasms and cramping and spasms. Or it should in theory. It might not help you. Exercise for sure. Oral contraceptives also to help to reduce prostaglandin production. So a lot of this is just your prostaglandins. So it's caused by prostaglandins. It's treated by inhibiting prostaglandins or decreasing their production. Awesome. And then I have kind of like amenorrhea is basically a type of dysmenorrhea. A for absence of, so yeah, A for without. Absence of menstrual cycle. But very particular. There's like a primary. When menses has not occurred by age 16. And then secondary cessation of menses. It's an example.
But you started a period and then something happened.
Yeah. So
Per your words.
yeah. So in this scenario, this is something that this isn't real. So obviously menopause has amenorrhea, but you can have amenorrhea without a menopause. So if it's something is causing you to not have your period for at least 3 months. I guess pregnancy. Yeah, pregnancy technically, yeah, pregnancy is one. Yeah. PCOS.
For my girl athletes in here.
Yeah.
Excessive exercise.
Yeah, so like pregnancy, menopause is one, of course. PCOS, excessive exercise. And then this one would be like abnormalities. So,
Underdevelopment.
yeah, underdeveloped ovaries, reproductive issues in general, or extreme malnutrition. So that's why teenagers need to eat, and they need to you need to make sure that they get the proper nutrition, calories, vitamins, minerals, protein. All right. So we'll kind of have a general treatment, and we'll just talk about centered around the underlying cause of amenorrhea. So just try to figure out what's causing it. Okay. And then lastly, menopause. Oh, I guess technically we go into infection, but at least for this section, reproductive problems, menopause. So around what time does it happen?
Now, no, for real. That's funny. For most females, okay. Some people just don't get it.
Some people start it early.
Mm.
If you had a very early period, you end up with early menopause.
Hmm.
If you had a late period, late menopause.
Yeah, 45 to 55.
They'll read the book or something. You get all of them. He's one of the girls.
Kaylin said Fidel keeps getting all the numbers right. He's secretly one of the girlies or something. He knows it all. He knows all the values. He's undercover. So, another thing to keep in mind, huh? The nail. I love that. I love that emote. I loved using that emote. I love that emote personally. So it's considered to be menopause when there's 1 year of consistent amenorrhea. All right. So what do we not, I guess, what do we, is this clear enough assessment here and then do it like that? Well, actually, I guess that's already kind of there. Okay, well, what are you assessing for like, what would be an abnormal finding in someone with menopause? So they have amenorrhea, so what would be some abnormal stuff?
If they start bleeding again after 1 year,
Yeah,
that's
that's
not,
a problem. Yeah. Like,
yes.
are we worried? Like, is that cancer? What's going on?
Mm-hmm.
Yeah. And Kaylin says, other than cancer, like, what's another potential cause? GI bleed, not from your vagina, unless you got like a fistula or something.
STD. Actually,
Hmm.
that's something I didn't think about.
It might be possible.
Yeah, that's a possibility, actually.
Yeah. So I guess so we talked about assess for bleeding as an abnormal finding for menopause. So something we can do is ask for HRT or like ask about HRT. Are they getting HRT? Because the patient, something that you can do for management includes HRT to manage hormonal shifts. And obviously, if you are receiving hormones again, your menopause is caused by the change in hormones. So if you're kind of restocking back up on those, you might start having postmenopausal bleeding because of the HRT. All right, so you want to rule that out as a thing. So yeah, if the patient comes in, it's like, oh, I'm bleeding, but I'm in menopause. You don't want to be like, oh, that could be cancer. You might be like, hey, do you do hormone replacement therapy, low doses of hormone replacement therapy to help with any with the symptoms or just the management? And they go like, oh yeah, well it's like, okay, that might be what that is. We can rule that out, or we can. Hmm. All right. Any questions on anything? Let's see if I have. Yeah, I'm a 10. Yeah, I'm a 10 pages because there's so many images. But the images are good. I think they're gonna help you guys a lot, especially this one. Yeah, Kaylin says that's the only reason she remembers Janica Master because I kept telling everyone, "Oh, dude, The Rock, but with like breast." Okay, so the two main infections that they really go over is your vulvovaginitis and your vulvitis. So what's the main difference between them? It's kind of in the name, but I know I definitely got confused a little bit at the start, and I know, I think Kaylin had a few people ask her about it.
Is one the infection and the other one is the inflammation?
Kind of. So your vulvitis. So vulvitis here is itis for inflammation. Your vulva, kind of like the outside your lips, the labia, region. And then you have here bulbo. So bulb again, the same root here. But then you also have, you still have itis here. You have vagin, so vagina.
Oh, it's like inside the vagina.
Yeah.
The
So that,
infection.
yeah, exactly. So your bulbovaginitis is both the labia and the inside, the vagina, but your vulvitis is just kind of like the outside
Mhm.
region. So I like, again, pictures. So this one for me is really helpful. So for bulbovaginitis, you can see here. Yeah, you can have a few different causes, and the focus is not really on like I can tell these all apart, blah blah blah. It's just kind of it's just kind of knowing one of them includes the vagina part, the cervix as well. Here's like some things that um some of the common infections that you'll see. So the yeast infection, as well as a few other stuff, comes with like fishy odor, foul smelling, uh, um, So you see here, this one doesn't actually mention anything about the smell. So yeah, some descriptions of the things you'll see, the types of discharge. Again, I don't think it goes into that deep of a detail, but I think it helps me because I remember being like, what's the difference? And then here's a picture of bulbitis. As you can see, this one's just focus on the outside part. Okay, so that's an easy way to think about that. So what are some causes of your bulbal vaginitis? So causes and signs and symptoms are kind of already listed up there. So you have I'll rewrite it because why not? Well, you guys kind of come up with the causes. Write the definition. We got STDs. Yep. Yeah. Tampons. The condoms cause a lot of issues. True. True. Oops. Spermicide. Nice. Good job. You guys really got this one down, huh? It's all the girlies. Hmm. Yeah. Good job. So yeah, antibiotics. So notice here, so right here you can see, and you didn't put the question mark. Okay, girl. Yeah, so here you can see here, it can happen from an imbalance of hormones or even the change in the flora. So antibiotics can also cause an effect in the natural flora, which includes natural like bacteria, the good bacterias. So that can then cause some of that, the opportunistic infections. So kind of like certain antibiotics, when you're really like immunosuppressed, you can have like so here you see this one, it's Candida albicans. So you can have this in your mouth as well. That's your oral thrush. So that's another bacteria, good bacteria that can become yeah, overgrown from like antibiotics, immunosuppression. So HIV, people with HIV or constantly people that are immunosuppressed can get oral thrush. And then on the same instance, so some antibiotics that are um can then affect the vaginal flora can then cause the yeast infection in there as well. Awesome. Some possum. Management. So let's kind of go over. So I guess we'll go over the medications, but I think the main way to do it is just what class of medication. Let's see for yeast infection. That's just based on what I have, the focus wasn't as much on the medications. It seemed like it was just like yeast infection meds. So I'm like, okay. And then we'll go over some general education. So what is pretty typical for fungal infections? Remember, yeast is fungal. Like an ending. What's a good ending for a lot of these common antifungals? Yeah. So a lot of the azoles. So some example is miconazole, fluconazole, metronidazole. So that's their flagyl. So, Oh, okay. Apparently, monostat's a household name. I did not know that. Oh yeah, if it's like over the counter. Yeah, so this is miconazole, aka monostat, fluconazole, aka diflucan, I guess. And then this is flagyl. That's the brand. So some general education, I think a lot of it can apply pretty much the same as your vulvitis. Wipe front to back, pretty good. What else can we do? We're yeah, I think that's from Kaplan, right?
Diego, I have a question.
Yeah.
So
What's
for
up?
yeast infection, you can use flagyl for yeast infection?
Yeah, so Flagyl is antifungal. So all the ones that end in azole are actually antifungal medication.
Oh, I didn't know that because I thought something different for yeast. I thought yeast
Hmm.
was different than
Yeah, so your yeast is like a fungal thing.
okay, no.
Yeah. So here you can see here metronidazole can be used for vaginal infections as well. Yeah, your yeast is in general. That is bread. So let's see, infection treatment for men. Ooh. Yeah, so examples of some antifungals you'll see here. Yeah, we talked the meconazole, traconazole. You see all of them end in azole. So yeah, metronidazole is still one of the ones you can get for it. But based on this, it seems like these ones that the first two that were mentioned are probably a little bit more specific because obviously this one can be used for general a lot of like a broad spectrum.
Mhm.
But it looks like these two are given more commonly or like they're probably more specialized or they're more specific.
Oh, okay.
Yeah, they're also
I
over
didn't
the
know that.
counter. Mhm.
I thought you used like diflucan. I didn't know you could use that. Thank you.
Yeah, but yeah, so on this page here on the Mayo Clinic, yeah, it's got the Monostat here, the Diflucan here. So yeah, it's depending on what the doctor wants to give.
Okay. Thank you.
Yeah. So we said we're caught none. These things. That's a Kaplan question. I'll just kind of put the sitz bath or cold compress for itching. Yes, no sprays, no douching. So, Kaylin asked, why would you not want to put the warm compress for itching? Yeah, it's gonna cost more itching. So your itching is kind of caused by that like partial inflammation and then that the blood flow. So if you have a warm compress, remember that that increases blood flow. It's gonna cause even more itching. So that's why it's cold in particular. And then the sitz bath, it's looks like this. So you're quite literally sitting in the bath. So basically just kind of like a soak. I think it's um so here's kind of the Walgreens version. Hmm. Apparently it treats hemorrhoids too. Yeah, I'm not sure. Honestly, I'm not sure if it's medicated or anything. Nice. Yeah. So then the vulvitis. Okay. Very similar, a lot of similar stuff here. You're gonna also have itching and burning sensation, but yeah, the cause is a little bit different because you can see that the inflammation, all this stuff is happening on the outside here. Can be a little bit, it's more on the inside and it has a little bit different causes. So what are some of the causes here? So it's contact with something. Yeah, your STDs are a little bit more associated with your vaginal because the PP go in the hole. Ow.
Contact dermatitis.
Yeah, so the big thing is gonna be your contact dermatitis and from what?
That was something to
That was more of like something to avoid to make it where's it over here? Oh, there goes a sign in here. Yeah. Because you don't want to keep irritating it. Yeah. Kaylin says for those who have eczema, what are some things you guys avoid if anyone here has eczema? Kaylin says she has 3 different types of eczema.
fragrance.
Yeah, so yep. So kind of all this. Yeah, I even put fragrance. What else? Kind of goes with that. I spelled fragrance wrong. Okay. They call in the notes it was like the feminine sprays.
So happy that it makes it.
Yeah, lotions. Kind of along that line. What else can you guys think of along that line?
Detergent, washing
Yep.
your clothes, and fabric
Uses that.
softener.
Yep. Fabric dyes, some soaps.
Aveeno and Dove.
Yeah.
The
Kayla.
material of the underwear.
Yeah, exactly. The material. Material of underwear. Yeah, non-scented is pretty much get whatever non-scented stuff you want. So that kind of goes with this. Oops. Oops, under war. It might be a war in there with how much inflammation there is here. Oh. Yeah, so and then your treatment is very similar. It's kind of we're gonna manage the itching, and a lot of that again is same thing, cold compress, the sitz bath, hydrocortisone for the inflammation. So again, cortisone, own as steroid, and we can do antibiotics when infection is present.
This is inflammation.
Yeah, so why would an infection be present? So this can, again, this is contact dermatitis, which doesn't have to mean that there's an infection, but there can be an infection. So why would there be, what would cause the infection to occur if there was one? So what is your main, not so much that. So remember, what is your main symptom with this? How does the bacteria get in there? Because remember, this isn't on the inside of, it's just on the outside, it's just the skin. So what must have we done to cause that?
Like contact.
Yeah, so what are we looking at here? So we made contact and it's kind of exacerbated from something we're already doing. It's maybe a little bit vague, but maybe you guys will get it.
Mm.
Yeah, Kaylin says think about your portal of entry.
Hygiene.
I'm sure that
I'm sure that plays in.
into it. So basically, how is it gonna get into the skin? What are we doing that causes portal of entry into the skin from from our symptoms?
Scratching?
Yeah. So for scratching, we can break skin, and then when we're breaking skin, that bacteria then gets in there, and then it starts an infection on the outside. So your main causes is contact dermatitis, but it can also get infected because you're scratching. So like like a secondhand infection.
Shaving.
Oh yeah, that can happen for sure. So does that make sense for everyone? Why you might have secondhand infection? Yep.
Yeah.
Yeah, and then the same thing can apply. I think you guys had the skin section. So like with your eczema and psoriasis, you can scratch, cause bleeding, but also infection risk. So remember about that. Whenever you're scratching, you're itching at something, even like the cancer patients, they might want to scratch their scalp and stuff. That can also lead to infection. They're already immunosuppressed, so things to think about. Are we running out of time? All right. 2:30 is a pretty good time to stop, but we're almost done. We're actually like exactly, I think we're exactly where we need to be on this. All right, so we talked about that. And then the education is pretty much the same. Front to back, wipe, no tight fitting clothing, proper underwear. So yeah, and just avoid the triggers. So these are your triggers right here.
That one came up with 222.
Yeah. All right. Well, so far that's pretty much all I got for you guys. Let me see if there's any other cool pictures I got. Think not for now. What I will leave you guys with, I think I'll give you guys this. So you guys can look through that and prepare for the next session on Sunday, which will include, we'll talk about STDs, reproductive disorders, hysterectomy. So I'll leave you guys with this. It's a little chart just so you guys have all the STDs in one place. And I think you guys already did this for homework anyways, but I think it was homework. Was it homework? Was it homework for you guys? Because it was homework for us. I'm just wondering. Oh, it was. Okay, cool. Yeah, so you guys already did it, so I don't feel like I can get in trouble for linking mine because you guys already did it anyways. Yeah. So again, this is what I did for homework, so if it's too much info, this doesn't mean whatever's in here is on the test or whatever. Some of this might be like extra info, but it's just like nice to have it in one place. Yeah. Yeah, or you can, make your own chart from it, add stuff that's not in here, or add stuff that you have on yours that's not in here. Yeah. Yeah. All right. Any questions overall on anything whatsoever? Hopefully the pictures help you guys a lot because I think it helps me on all this stuff here. Yeah. I'll give this to you guys as well. Make that into a PDF. Yeah, so I'll give you guys a PDF and then on Sunday we'll finish it off and then you guys can get the even more updated PDF, I guess. So for now you guys can have this. So nice to have over the Oh, yeah, Kaylin wanted to mention good job on the midterm scores. I think your average was really good. It was like 85% average or something like that. Let me get you guys the thing. Sorry. Women's health.
I think they curved it.
Fair.
A
No.
win's a win.
A win's yeah, a win's a
win's a
win.
win.
We actually just had our exam yesterday and they curved it. Or they fixed their mistakes because obviously we weren't wrong. They were wrong. Yeah, so here's the PDF here. Awesome. That was surprisingly that was smoother than I thought it would be when I saw that I was gonna do women's health as a man. I was like, oh,
you're officially one of the girlies
Oh, I'm
now.
I'm one of the girlies now.
You're
Okay.
an unofficial girl.
All right. Let me do my emote.
Oh, the tail.
There you go.
Oh, Giselle did it too.
Huh?
Giselle did it too. I saw it pop up on the.
Oh, really?
Yeah. You too.
Yeah, awesome. Yeah, you too. Yeah, I think that's everything for now. So yeah, you guys are free to go. Come back Sunday or watch the recording. I know some of you guys have clinical on Sunday with Miss.
Thank you again, both of you guys.
Yeah, of course. And just keep up everything. Keep up the good work.
Thank you.
Yeah, so I'm gonna stop recording.